meningeal artery, okay, super important. And then there is loss of consciousness right after whatever the insult is, okay. They have a lucid interval where everybody's like, this is great, you're fine, no big deal. And then they have significant deterioration after that, okay? The other thing is that they may have vomiting with no nausea. So oftentimes, right, before you guys vomit, you're like, oh God, I don't feel very good, this is great. Nope, this is where they're just projectile vomiting right away, okay? They also could be complaining of a headache during that lucid interval. Obviously, maybe they got hit in the head with a hammer and they're gonna be like, my head hurts, right? And then they could be a little bit confused, okay? Again, what's the most sensitive indicator of a neurological status?
LOC.
LOC, level of consciousness, okay? So again, with the deterioration, they're going to decrease the level of consciousness, okay? They're gonna be altered. So diagnostics, always CT. MRIs later, remember, MRI takes some time, okay? We do not have time. This is a medical emergency, so they're gonna scan their head in the CT, and then they're going to emergently take them to surgery, okay? They're emergently going to take them to surgery. Because again, they want to control that bleed, okay? They need a craniotomy. That's the treatment for epidural hematoma, cranium. Okay, you could see burr holes, but again, they need to control that bleed. They need a cranium. They need a craniotomy. Okay, they could come back with an EVD, a ventriculostomy. Okay, which would help us monitor ICP. Okay, I like that you put elevate the head of the bed. You could see that they could have 3% or mannitol if there's some residual cerebral edema. Absolutely. Okay, and then seizure precautions. Absolutely. Seizure precautions. Anytime there's anything in your brain that's not supposed to be there, right? There is blood in your brain, but where it is in your tissue, that's not where it's supposed to be. You could be at risk for seizures, okay? Now, we can't, the hammer to the head has already happened, right? So how are we going to prevent, say that they went to the surgery, they got their surgery, they got their cranium, they're coming back, you're in the ICU. How are you going to prevent secondary brain injury?
Falls. Reduce stimulus.
Okay, so again, we have to think about secondary brain injury. We need to be thinking about oxygenation, airway, so ABC. That's the easiest way, okay? Secondary brain injury, think about ABC. A is airway, so we need to control the pH. We don't want them acidotic, we don't want them alkaline. Because we know that if someone gets acidotic, right, that can mess with your cerebral perfusion pressure, right? It can mess with your CBF, your cerebral blood flow. Okay, so A is airway, that's controlling our pH. B is breathing, that's preventing hypoxemia, right? We want everyone to have oxygenation in their brain, right? That makes sense. C is circulation. We want to prevent hypotension, right? Why? Well, MAP minus ICP equals CPP. So we want to make sure that we have an adequate MAP, okay? Because sure, this person, they can come back and they can still have residual increased ICPs, right? So we want to make sure that we are ensuring CPP is still high and good. Does that make sense? Okay, this is with all of the injuries that we're talking about. Prevent secondary brain injury. A, B, C, airway, control pH. B, breathing, prevent hypoxemia. C, circulation, make sure they have a blood pressure. Okay, does that make sense? Okay. Okay, next one. Sudden explosive headache and hypertension as a significant risk factor. Which one is that? What do you think? Subarachnoid, okay, perfect. So subarachnoid hemorrhage, okay? So oftentimes the person has a history of really significant hypertension. That's a risk factor, right? They have a cerebral aneurysm. Remember we talked about years ago when we talked about our AAA, right? Our abdominal aortic aneurysm, very similar. You have a ballooning of a vessel. Thank you, Hayden, for this lovely picture, right? And so there is a rupture, cerebral, in your brain, aneurysm, ballooning, right? So there's a rupture of it. It could also be from an AVM or trauma, okay? You guys astutely identified. There's a classic triad that happens with subarachnoid hemorrhage. The classic triad, again, put a star by this, sudden severe headache, okay? Recently I had a migraine and I told Kevin, my significant other, I said, what if I have a subarachnoid hemorrhage? And he's like, you're insane. And I was like, but I have the worst headache I've ever had. I took 4 Advil, I felt much better. Clearly I did not have a subarachnoid hemorrhage, okay? This is where the hypochondriacness all will set in once you guys are all nurses, okay? So, sudden severe headache. So again, this headache is not relieved by anything, okay? It's not really, you could take the bottle of Advil and it would not help, okay? And then nuchal rigidity, that's hard word for me to say, everyone has them. And then altered level of consciousness, okay? So this is the classic triad of symptoms that you will see, okay? Again, you guys, CT scan. This is going to be king. The diagnostics for everyone is a CT scan. Everyone will do not pass go, do not collect $200 unless you've had a CT scan of their head. Okay, yes, a CTA, cerebral angiography, will give you a more detailed situation. So you may have a CT with non-contrast and a CT with contrast, okay? That's gonna help identify the vessels more completely, okay? And then treatment, right? It depends on how big the aneurysm is and the bleed, okay? You could see that they go to surgery. Do you have that here? They could go to surgery.
Yeah, right.
Clipping, thank you. Cerebral eclipse. You could see that they go, but again, we wanna make sure antihypertensives controlling their blood pressure, pain medication, antianemics. Again, all of these things, interestingly enough, analgesics, antianemics, are going to help prevent that increase in ICP, right? And so, again, with subarachnoid hemorrhage, these are precautions, monitor ICP, bed rest, reduce stimuli. Great, I love that. All of these people are at risk for seizures. All of these people are at risk. So everyone should have a seizure precautions. Try to say that 20 times fast. And then, most importantly with subarachnoid hemorrhage, they are at risk for vasospasms. After they have cerebral clippings in surgery, they're at risk for vasospasms, okay? How we treat that and avoid that is we give them a calcium channel blocker called nimodipine. Calcium channel blocker called nimodipine. So we want to prevent them from having vasospasms. Questions about this, subarachnoid hemorrhage? Make sure you understand how to identify these, okay? Patient involved in a ground level fall, hit head, venous, and origin. Who are we talking about? We only got 2 left.
Subdural.
Yes, subdural. Okay. So these are the people, right? These, guys, I love that you put shaken baby syndrome on our reason. I love it. You guys can talk about that when you get to pediatrics next week, okay? So this one is huge, right? Alcohol use in elderly. These people come in with a subdurals, okay? These people come in, and what happens oftentimes, trauma, right, is, do we have falls on here? I'm just gonna write it here, falls. They're falling on their head. They're tripping and they're falling, right? Elderly and alcohol use. These are the people that are coming in with subdural hematomas, okay? This is a big one, headache and confusion, absolutely. Again, it depends, right? These people can have this for a long time. Why is it different than the epidural? Because the blood, where the blood's coming is different. Artery, it's gushing. Venous, it's dribbling, okay? And so again, this might take a while to have them, present. They may just complain of, hey, I have some double vision going on. I have a little bit of a headache. Maybe they're a little bit confused. The symptoms can be a lot more subtle in a subdural hematoma, okay? Or they don't, especially in the elderly, they don't present at all. My grandpa had one. He had a CT scan for something else, didn't even know he had it, okay? I don't know when he fell, but he did, right? Again, I love that you guys included this, well done. Cushing's triad. When does Cushing's triad happen?
Late game.
Late? Is that what you're saying, late?
Yeah.
Yes, late. So this Cushing's triad, if you see this is a medical emergency, right? So you have widened pulse pressure with a high systolic, okay? High systolic, widened pulse pressure, bradycardia, and irregular respirations. If you see Cushing's triad, this is a medical emergency. You best be thinking about what you need to do to prevent herniation, because that's where the patient is headed. Okay, if you see Cushing's triad, they're heading for herniation. Okay, diagnostics, again, CT scan, right? CT scan. Always going to be king over MRI. MRI takes time. Yes, you can eventually have an MRI, but CT scan is the #1 diagnostic. Okay. Treatment depends on the severity. Absolutely, I love it. Small observation bed rest, yes. Large surgery, and you could see that they would need to evacuate the blood. They could have a craniotomy, okay. This person could come back with an EVD, a ventriculostomy, okay. And then anticonvulsants, yes, everyone, again, at risk for seizures, okay. Do you want someone to be on anti-coax? Why would we want them to be on anti-coax?
That's gonna increase bleeding.
That would increase the bleeding. I don't know what.
That might increase the bleed. So they're probably not gonna be on any anticoagulants for a little bit, right? Until this resolves, okay? I love that you put this though. You're checking your coags, your CBC, and then, yeah, neuroassessment. Okay, all of these people are having serial neuroassessments, all of them, right? And then what are we doing to prevent secondary brain injury?
Prevent falls, make sure blood pressure is good.
ABCs, okay, good. I mean, I love that you're saying falls, but that's not specifically gonna help us prevent that secondary brain injury, right? Because again, they already fell. You can't go back in time and prevent them from falling,
On the Betty.
right? But you can help to make sure their brain is oxygenated, there's no acidosis, and that they have a good blood pressure, okay? Questions about subdural hematomas? Okay, you guys are like, my brain is on fire. Okay, patient suffered blood trauma in an MVA, shearing of small blood vessels occurred. Last but not least, we have our intracerebral hematoma, okay? This is a little bit different because it's somewhere in the middle of the brain, okay? It's a little bit harder to get to. So, like your book points out, there's lots of causes, okay? Don't get caught up on the causes, okay? I need you to understand that depending on what it is, the treatment could be a little bit different. So for example, if you have shearing of blood vessels from an NVA, that's going to probably be treated a little bit different than an intracranial tumor, okay? So again, figuring out what the cause is going to steer your treatment a little bit different, okay? Like complications from an anticoagulant therapy, you could stop the anticoagulant, right? Stop the anticoagulant, that's not necessarily gonna be the same treatment as the trauma. Does that make sense? Okay, and then neurological defects, difficulty speaking, seizures, headaches, nausea and vomiting, yes. And then also, ALC, I didn't realize that this was on. My face is going to be very large in it. Diagnostic CT, right? I love that you're putting MRI, but again, CT is the quickest diagnostic that you will have. Supportive care, head of the bed up, fall precautions, vital signs monitoring, blood glucose. This is a given, you guys. This is a given. Absolutely, everyone has their vital signs monitored, right? Everyone, you're looking at that. I think it's fine you put that, but again, ABCs, right? Airway, breathing, and circulation. You'll hear that a lot when we get to trauma, okay? Pain management, antihypertensives, maybe a craniotomy, but again, it depends on where the bleed is, you guys. If it's in the middle of the brain, sometimes they can't get to it. Okay, sometimes they can't get to it. So these are the people, these intracerebral hematoma people are going to be the people that are going to have an EVD, a ventriculostomy. The ones that you're going to be worried about ICP, okay? Because again, epidural and subdural, even subarachnoid, these people over here can have surgery and evacuate the bleed or take care of it, right? These people, maybe not. It depends on the cause. So these people are at the highest risk for cerebral edema and for high ICP. So these people, depending on how big the bleed is, obviously, are going to be the ones that have the ventriculostomy that you are going to be worried about. You're going to be watching their ICP, okay? You're worried about that secondary brain injury, okay? These are the people that you are doing serial neuro checks on, okay? What I mean by that is that you could be checking them every hour, going in and doing a complete neuro assessment, okay? Questions? No? You guys good? with these. We won't erase them yet. Last but not least, all of these, again, I'm focusing on the intracerebral hematoma as being like a trauma situation, traumatic brain injury, if you will. What's happening? Why did it do that? Oh, there. Okay. Okay, so what I want you to be thinking about is I want you to be thinking about nursing interventions for TBIs. What are your priorities? We've kind of talked about them, but I want you to put them up here to slam them home, okay, for just traumatic brain injuries. What are you worried about?
ABCs.
Okay, great, put it in there.
Well,
You can't prevent the initial insult, right? It already happened. What are you doing to support the patient thereafter?
yeah, I can change that. Start reading from the brain. Yeah.
Yes, okay, good. We have ABCs in there, secondary brain injury. Perfect.
Scratch Miss Alicia Hyde.
So you're preventing acidosis, you're controlling that pH. You're preventing hypoxemia, so you're optimizing the breathing. If their GCS is 5, what are you worried about? Their GCS is 5, what are you worried about?
Too much pressure on the brain.
What?
Too much pressure on the brain. Stopping them from.
You said pressure on the brain is what you said?
Yeah.
Okay, sure. What else? What else are you worried about? Yes, airway. Anybody that has a GCS less than 8, you need to be thinking about airway, that they're not able to protect it, right? And again, just like I talked about, ABCs. If you're not able to protect your airway, do you not think that that person is going to have some sort of secondary brain injury? They're going to become acidotic, they're going to become hypoxic. Do you think your brain is going to like that? No. So you need to optimize your cerebral blood flow and your CPP, cerebral perfusion pressure, right? How do we do that? We lower the ICP and we increase MAP, or make sure that MAP is good, right? Okay, so again, ABCs. I'm gonna drill that into your head. ABCs. Frequent neurochecks, huge, okay? Just because they had that initial insult, things can get worse. Cerebral edema can occur. I'll never forget in flag, this is like ingrained in my brain. You'll have patients that you take care of that you will never ever forget. Young girl, I think she was like 18, tried to drive her car off a cliff in Flagstaff. She somehow lived, right? And she had so many injuries, I can't even begin to tell you. She actually probably should have been sent down here to have ECMO, to be honest, because her, she had such significant pulmonary contusions. We had such a hard time ventilating her. She was actually on an oscillator. Anyways, long story short, she developed and started to exhibit Cushing's triad, right? She didn't have an initial brain injury, but what happened is that cerebral edema, because she had an intracerebral hematoma that it was small, the cerebral edema became super, super significant, so much so that she herniated right before our eyes. And she was too unstable to even take her to CT, too unstable to even have surgery, okay? So again, why I tell you that is not to tell you a sad story, but to tell you that frequent neurochecks are so, so, so important. Again, they're going to change. is your patient's ventilated versus non-ventilated, they're going to change, right? You can go in and have a conversation with someone and identify if they're alert and oriented, their level of consciousness. You can check their pupils. If they're intubated, it's going to be a little bit different, okay? We are making sure that we're preventing that secondary brain injury, right? Head of the bed up, seizure precautions, I love that. If there are trauma, yeah, C-spine precautions always, immobilize that spine, okay? We also want to think about nutrition. I know you're like, Professor Bloor, is that low on the totem pole? No, not necessarily. We need to make sure that we are optimizing nutrition, just like shock, right? Hint, hint, shock. Remember that test you're taking later today? Shock, enteral feeds are king, okay? Enteral feeds are king. Just because this patient has something wrong with their brain does not mean that they're still at risk for the other things, okay? They were involved in a trauma, they're at risk for hypovolemic shock, right? Because they're bleeding, plus they have a neuro injury, okay? So nutrition, enteral feeds, right? Positioning, preventing pressure ulcers, preventing DVTs, all things make sense, right? And then making sure we're lessening ICP with non-invasive measures, reducing that stimuli, separating your care, right? No suctioning. If the patient's vomiting, you're trying to help them with that, okay? So lessening ICP and optimizing that, all things with TBIs, okay? Questions about this? No? Okay, that's great. Let's take a 5-minute break. Come back at 11:13, and we will get into trauma and